I'm Helen Latch from the School of Nursing. We have David Toll from Family and Community Medicine and IPE, Pam Hudgens from Social Work, John Worley Medicine, and Travis Fretz from Speech Pathology. So thank you all, and you can start when ready.
All right, so we're Team 3. I'm Tara Dower, and I'm a nursing student. I'm
Connell Gallagher, and I'm a medical student.
I'm Kylie Stockley, and I'm in speech language pathology.
And I'm Danielle Thomas. I'm a doctoral student in the medical family therapy program. All right, so what we're going to do today is we're going to introduce you first to Henry, to meet him first as a patient before we name his disease. So what we've learned about Henry is that he is retired. He used to work as an engineer. He does have a college education. Context with that is it happened right during the desegregation movement. We know that his support system and his family is very important to him as a key value, and he also values his community support both within his neighbor and the Baptist church. He came to us at Salud Hospital as a COPD patient. Okay, so a visual in family therapy, this just presents, again, the family genogram. So what you'll see up here is you'll notice a variety of losses that Henry has experienced. He lost his son physically, and that is his wife Betty, who also has her son Ty. So Henry's grandson and daughter-in-law are still alive, and Eartha has recently been diagnosed with Alzheimer's disease. So he's also experiencing the psychological loss of his wife as that disease progresses. With his anxiety and depression symptoms that he has reported, this has been an ongoing difficulty for him to manage. So we're attempting to care for those needs as well as acknowledging those injuries over time so we keep care then holistically for Henry's needs. All right, so our personalized care plan for him. We first want to start with his strengths. So we really want to pull out what is he bringing to us that we feel like are really strong points for him to focus on. He still loves his wife. He still really values family as a priority. He feels connected to his community, not only through his religion and spirituality, but through the community that he also feels supported by, such as his neighbor. He is able to still have autonomy, which is really important to him, and have independence. And he recognizes his need for assistance. So there's a lot going on right now, and he does recognize the need for help. Some concerns that Henry told us is that his wife is becoming more dependent on him, has an increased need for caretaking, so that has resulted in some caregiver strain that Henry has experienced. He also noted possible symptoms related to depression as well as anxiety as that has progressed over time. These concerns, again, may have been caused by his relationship with his anxiety and depression, not knowing really how to deal with that, how to name it, the illness that has now been brought into the system, and again, that's very complicated. Although it was recently named, he has been struggling with this for a long time, so even before the illness was specifically named and introduced into the system. And again, possible financial problems as well, due to the ongoing medications that he's being prescribed. Okay, so I'd like to introduce us. We are the Green Team, and so we're a group of healthcare professionals that are always working together, so that way we know each other, we know each other's tendencies, how we work well together. And so a part of our team, we have a primary care physician, we have a nurse, we have a respiratory therapist, a social worker, we have occupational and physical therapy, we have a speech-language pathologist, a medical family therapist, we have pharmacy on board, and we also have a dietitian. And so, from transferring his care from the acute facility that he's in to our pulmonary rehab facility, we're using SBAR communication so we can know exactly who this is and what's going on. So, when talking and bringing Henry to our facility, we're going to introduce that we're doctors, nurses, physical therapy, and our roles in transferring this patient and what we'll be doing for this patient. We would hope that the acute facility would tell us Henry's situation, and so they would let us know that he has a COPD exacerbation, and they're also concerned that he might have pneumonia in the works. They would tell us his concerns. They would also let us know that he might have some anxiety and might not know fully what's going on with his disease process. They would tell us his background, so they would tell us his current vital signs, any labs that they've drawn or that they'd like us to draw in the process of his pulmonary rehab stay.
the assignment. So they would kind of tell us what the situation is that they have for him. So he has a COPD exacerbation, and then what they expect his care to be once he's transferred. And then they'd also make their recommendations for us as the team, if there's any labs that are pending or that we should look into, or any recommendations for their care that we might not know about until they let us know that. And all of this would be done in person. So we'd all meet as a group with his acute care team, and we'd answer or ask any questions that we might have about Henry's care.
Definitely. And the way we want to frame how we approach Henry's treatment is through these shared care goals. So obvious ones, prevent disease progression, going along with that, relieving symptoms, more specific things, exercise tolerance, and I think a big point we wanted to stress was to promote his participation in his care, his active involvement, and again going along with treating exacerbations, smoking cessation, and quality of life in a variety of ways.
And so to make a visual of our goals that we had, we used a key driver diagram. And so what you can see is Henry is our patient, and as a whole, as interprofessionals, we all have a lot of the same goals. And so in our global aim of improving Henry's quality of life with his COPD, we found that we'd like to prevent his progression and complications, we'd like to maintain his safety and health education, we'd like to relieve the current COPD symptoms he's having, we'd like to improve his nutrition and safe swallow function, improve his exercise tolerance, definitely promote smoking cessation, and then on top of that, we'd like to enhance the coordination of his care. And so intervention-wise, we're going to go over that in his treatment plan, but as you can see, we're all really interconnected. All of us have the same goals, and we're all working together as one unit.
Okay, so the following are some safety issues that we talked about as a team and that we want to make sure that we educate the family on before they go home. So medication error, fall risk, fire risk, so making sure that Eartha isn't in the kitchen cooking meals by herself, acute exacerbation risk, nutrition, so in his file it said that he's only eating 50% or less of his meals, so making sure that when he does go home that he is going to continue to meet his nutrition needs and maintain his weight. Maintaining overall cognition, developing an action plan, and then depression and anxiety. And this comes into play also with Eartha, who is his spouse who has Alzheimer's, so this can cause depression for him, create a lot of anxiety, so just developing an action plan for how they're going to deal with certain situations when they get home.
And as far as innovative care, there are obviously a lot of things up there, but a couple things we wanted to highlight. One, electronic monitoring. Not only the use of EMR, but certain other things. I've been involved with a startup called ePharmix that is really geared towards fall monitoring, simple text-based system. And another one we wanted to highlight was community-based COPD resources, and that just speaks to things like support groups, people who also have to deal with, people who deal with his wife's condition, and just how they manage that.
So during his 1-week pulmonary rehab stay, these are some of the things that we want to highlight. We're going to definitely want to educate him, work on exercise reconditioning, work on oxygen dosing, nutrition education, energy conservation techniques, and then any additional recommendations to the physicians, such as additional tests that we may feel would help.
Okay, so here listed we have his treatment plan. The goal is to have Henry have a better quality of life. And so as the nurse manager of his care, I would facilitate that the green team is all on the same page in his treatment.
And Henry's physician's plan of care generally starts off with medications. And there's a medication plan of care that we don't need to go over right now, set out in our packet. Follow-ups, we just want to start off weekly, then progressively move to monthly, theoretically as his condition improves. Diagnostic tests, obviously just simple vitals, blood pressure, seeing how his disease is progressing, and obviously any sort of diagnostic tests that other specialties would need a physician to order. Also, another thing I wanted to highlight was medication monitoring. He's on a lot of meds right now, and I think it's 7 to 10 medications. That's a lot, not only for someone to be compliant with, but also for us to be sure that there aren't going to be any harmful drug-drug interactions. So if we can taper those and just see, what diseases and what conditions are the most important, I'd really like to do that over the course of the next few months.
As Henry's nurse, I would definitely be interested in his health maintenance. I'd be monitoring his vital signs, taking into account that he does have hypertension, so I would be monitoring that in addition to his COPD. I'd be looking into incentive spirometry and making sure that his FEV1 is not diminishing, meaning that his COPD is getting worse. I would be looking at his O2 stats, trying to keep them above 88%. In addition to educating him, he's going home on oxygen and he's never done that before. And so there's a lot of things that come with that to educate the patient. In addition to advanced life planning, his wife has potential Alzheimer's, and so with that, he should have an advance directive or some sort of living will in case something did happen to him. And because he has a daughter-in-law on board as well, I feel like she should be a part of the education. That way, everybody is all on the same page in terms of his advanced life planning. And then just discharge education to independent living. He really values being independent, and so I'd like to teach him as much as I can about home fall risk, caregiver burden, things that he'll deal with in his daily, everyday life.
Okay, and so for social work, we'll also be coordinating care. This means transportation to any appointments outside of any of the facilities, outside of the home. It will also be dealing with insurance related to medications that may come up, as well as how can we reduce the cost. So in any ways, what local resources are available to make sure not only is this patient well cared for, that but we're really offering appropriate resources for the context with which he's in.
So broadly, PT and OT will work on safety during ambulatory tasks, and this will include energy conservation for activities of daily living. They're going to focus on improving overall muscle strength and balance through exercises and tests such as determining if he can handle a 6-minute walk, if he can transfer from his bed to the bathroom safely, move around his house safely when he gets home, and then also breathing exercises, chest physiotherapy, and education. In terms of speech, so Henry has COPD and he has a history of smoking, which puts him at a risk for aspiration. So it will be very important to facilitate bedside swallow evals and possibly modified barium swallow study or video fluoroscopy, to determine if he is aspirating, and if he is, then develop a plan for Henry to still go home but maintain his health. Speech will also focus on improving coordination of respiration and swallowing, as well as monitor cognition and Henry's ability to perform swallowing strategies if the plan goes that direction.
As a medical family therapist, I'd really be focusing on narrative therapy. What that means is I meet with the client and hear about their story. I mentioned earlier the loss that he had of his son. Now he also may have the psychological loss of his life. But we also would really be focusing on the themes of loss in general. Here's a man who's worked his whole life, is in a stage of retirement, and is now being told that they're naming an illness, that they're naming his wife with a potential disease that doesn't get better. COPD in the same way also progresses. So what we're really hoping to do through this process is really help validate and acknowledge those losses, not again only physically, but the dreams and wishes that this man may have had that are so closely integrated within his values. We also know that grief is very related to the mind and body. So by sharing his grief story, I want to see how does that connect with medication adherence? How does that connect with this whole plan? And how do we find meaning and purpose when so much loss is on a patient? So with Henry, helping him carry that loss through processing, as long as working with the medical family to really find that support and purpose again. Okay, this was just a brief document just to show one of the ways the team care can work together. So with a Google Doc, we would have Henry labeled as a case number just to protect confidentiality. And what we're really looking at here is clustered care. So Again, being in the context of working with Henry, we are not going to put him through 8 hours of therapy. As much as it may benefit everyone to be there on Monday, we are instead going to recommend more clustered care, where we're just doing a few sessions, kind of briefly at different days. And again, this was just a brief overview, and again, with the idea that the nurse would be there the most consistently seeing Henry every day, which again is why we decided as a team to make her the case manager. So she will have the most intimate relationship with Henry and checking in with his needs. And then again, as team members come in, it will be our job to build that trust so Henry knows who's coming into his relationship as those grow and the medical team changes across context.
So in understanding our treatment plan and the safety risks that put Henry at risk, we picked smoking cessation was a huge one. He's about to be on oxygen and he's still a smoker. So with that comes the risk of fire, it comes the risk of, he might not even know how to hold his oxygen tank next to him or store it appropriately. So we would definitely discuss options for smoking cessation, like a nicotine patch or even just a smoking quit plan. We'd like to go over the oxygen risks. You can't wear Vaseline around where you're getting oxygen because it's flammable and he may not know that. We'd like to discuss his cultural diversity and just make sure that he's not experiencing anybody else's prejudice against him and against what he knows and doesn't know about his disease. We'd like to talk about technology with him. Based on when we had talked to Henry, he has a computer, he uses cell phone technology, and so with that we'd like to educate him on the e-pharmacs that Colin would like to implement, and just keeping up with his patient charts on something like our Salud Care website. Additionally, we'd like to talk to him about diet and nutrition since he is not properly eating, and so we'd like to tell him he needs to intake a lot of fluids, high protein, and try to thin those secretions. And then we'd like to give caregiver support. We're going to give him a caregiver burden test. And so with that, we can go over it and see where he needs assistance, where is his stress level, in addition to giving him a check for home safety, so he can look at his house and say, oh, I have a lot of rugs, I might trip, especially with my oxygen, or even just educating him on fall risks.
So ultimately, when we're looking at Henry's outcomes and his quality of life, and of course his wife's quality of life, we want to use some specific measures so we can see progression of that. So the COPD CAT test, that's just like a simple survey that he can take prior to entering rehab and after, and even further in the future, to see how he feels about his COPD. Also looking at obviously like oxygen stats, pulse oximetry, incisive spirometry, activities of daily living tolerance, medication adherence, and a COPD action plan. Is that being used? When he has an exacerbation, did he follow the steps? And these ways we can both measure how well Henry is doing and how well we're doing.
Some additional ways to measure the outcomes of Henry's overall quality of life are through his diet. So the dietitian will play a huge role here in helping him figure out what kind of foods are good for him to eat, figuring out if he is clear to eat solid foods, because right now they put him on a soft diet, and then overall maintaining his healthy weight. They'll also focus on emotional health, so what is his depression level, how high is his anxiety, and how can we help facilitate lowering that, helping him transfer to an independent living from the rehab setting. And then overall creating a COPD action plan for him. And that will help reduce the depression and anxiety overall as well.
And then understanding Henry's needs, we found that he'd like to be independent, but he does not want to be away from his wife and would like to be closer to his family. So he made the decision to move from Poplar Bluff to St. Louis. So we found him a wonderful independent and assisted living home called the Nazareth Living Center. So they have memory care that supports Bertha's Alzheimer's, as well as it's a few miles away from Betty and Ty, so he can still be close to his family. They offer him meals every day appropriate to his diet. They transport him to facility activities or to his doctor's appointments. They oversee his medication, which was the source of his anxiety. And they also have pastoral care, which he was very concerned about his church community, and so that really targets his needs. And it accepts Medicare, which a cost was an issue as well. So So overall, we decided that the lessons we've learned is COPD is extremely complex and it involves a lot of people in Henry's care. Communication and the continuation of his care is just as important to patient outcomes as his treatment itself. If there's some sort of loss of communication, his treatment can really suffer. And taking Henry's emotional status and concerns into account directly impacts his outcomes. If we didn't take that into account, he might not take his medicine, he might be depressed. So by understanding his needs and making that a part of our goals as well, we feel like we could give Henry the best care that we could for his COPD.
Great. That's your time.
I'd just like to say that you really went up, there was a lot of depth of what you thought about and a lot of pulling from so many sources of research and sort of just geriatric, pulmonary medicine kinds of things, social too. So, thank you.
I mean, you did a great job of putting stuff together, as does everybody else. So all I can say is you guys are a hell of a lot more bright than the people who get on the floors as far as the medical students is concerned. And you're way ahead of the people I'm going to see in about a year and a half. I won't talk about the other disciplines, but you guys are superb. I mean, one of the things I should point out, see, you brought him up to St. Louis, and I know his family was nearby, is if you ever want to go and you live in the country, the nursing facilities in the country, nursing homes, assisted living, are so much better than what you get. Yeah, and it's because the community's looking after you. When you come into a city, you lose that community piece. So don't think that he would have been better off without blah, you know, and it's really very true, unfortunately. But you did a wonderful job, and I think that you put it together extraordinarily well.
I was really impressed by the way that you identified and brought in each of the different professional tools that you might use. So like the MFP, looking at, these are different issues when we track out some of the graphic look of the family, and it gives it an image, and then also with starting with the patient, and then how are these goals being addressed by different people, really showed the possible interactions with the professions. So I thought that was tremendous, and it showed the overlap and the collaborative opportunities. How did you as a team go from those individual to really this team approach to the overall patient care? Because you had one of the strongest presentations in terms of the individual contributions, and I'm just interested, and your teamwork was good. So I'm interested how you went from those two shifts.
So, well, from my perspective, I think it was helpful, one, that we actually all spoke first to how I would use it just from my lens. So I always like to think of, here's my therapy lens and here's my integrative lens. So if I'm in my therapy lens, I'm seeing Henry completely this way. I'm not worried about any thing, but how do I switch then to that integrative lens? And it was so interesting hearing, I mean, you gave the example with the Vaseline, you gave the example with the oxygen and cognition, you mentioned a lot of the e-pharma, I mean, just, so once you switch that lens for me, it makes me realize how complex his life is and how hard that must be if you thought he was the only one in charge of his care.
And I think identifying which profession, while we might have overlapping goals, does each goal or accomplishes each goal most effectively.
Yeah.
The other thing that came through was by doing that, what you're describing and what was in your presentation, it had a much more comprehensive feel to that common goal, including very much what the patient's goals were. So with all those goals, it seemed to support what the roles might be and who would be best contributing. So you did a good job. It seemed like the process helped you do that, but also the presentation made that very clear as well.
I like to comment on starting with strengths and starting with the picture, person first. And that doesn't always happen.
Right. Yeah, we felt that it was very important to talk about his strengths and what he can do before talking about these are all the things that he can't do and these are all the problems, but see him as a person first.
And from the medical student's point of view, the fact that you let the nurse take the lead is phenomenal. Because clearly, for interprofessional teams, often when you have a physician in them, and I'm the worst example in the world, they tend to do more speaking than anyone else. And it's really important that the team feels involved. And you guys did a wonderful job of making it feel like it was 4 of you working together rather than each of you individually.
I think the decision just came down to her seeing way more than us.
Yeah, I was gonna say, we started out, once we met, it was more of a discussion, like we discussed.
It's fine. You did the right thing no matter how you got there.
I was like, I started to just take it.
And I only really said that for Helen's benefit. So,
You really were exceptional. You did an exceptional job.
Thank you so much.
Great, very good.
Very well organized, flowed.
Extremely complex graphs.
Yeah.
Those
Yeah.
are- was that?
That's her.
Those are from my CNL degree.
We have a new program which is a clinical nurse leader, so they learn really quality improvement tools.
So that's where that came from, yeah.
Yeah.
Yeah, and so I was really able, like, I was really happy I could use
So
those.
they look really good.
I don't teach that part, but I know what she's getting, so.
So can you share those with the rest of us?
Very
So
impressive.
if you can have the opportunity to get a CNL nurse on your team.
That's right.
Yeah, absolutely.
That's what you need on
It's an
your
up and
floor.
coming role, so we're hoping to get that in more care places, facilities.
Very nice.
Good job.
Thank you so much.
Thank you, guys.